title of his presentation this time is going to be Treatment Beyond Sorafenib. What are the options? I'm really anxious to know what's beyond sorafenib as an oncologist.
I know. Thank you so much. So I promise this is my last talk for the day. And the task was, as Dr. Lubna mentioned, is very easy. There is no standard of care. So that's what made it more interesting to me. So I split the pathogenesis kind of talk between the first one and the second one to make it a little bit more interesting. I'm going to also talk about some inherent problems with the phase 2 studies in HCC in general that led to failed phase 3 studies. So this is the outline. I'm going to talk about some published second-line studies focusing on phase 3 studies, and then allude to challenges to those phase 3 studies and why all of them turned out to be negative, and then move to challenges and solutions related to research bias that led to that in the first place, which is applicable to a lot of other settings. For example, and the oncologists would appreciate that more, it's a very similar story to the gemcitabine in pancreatic cancer, which took about 15 years to move from single agent to combined agents. So, and then we will conclude. So let's quickly move to some published data. Everolimus study was negative for the second line setting, and that was reported in 2014, and that was after a promising couple of phase 2 studies showing significant activity in a phase 2 setting. Another study, which was CMET, moved from randomized phase 2 to second-line study phase 3, tivantinib. So this study looked into CMET expression as defined by immunohistochemistry. And the interesting part was when they looked into low versus high expression of CMET as measured by immunohistochemistry, there was a significant difference in TTP and overall survival. So in a way, this is actually one of the first attempts to look into real targeted therapy approaches for HCC. So the phase 3 study is still ongoing. We're all excited about this approach because it moved from a good conducted phase 2 study, a randomized fashion, to a phase 3 based on molecular data. And then, of course, we're very familiar with the Brevanib data as well, which after 5 phase 2 studies in different patient populations and so on, showing some signal of activity, this study, the phase 3 study, turned out to be negative. And then bevacizumab and erlotinib combination, which did not move to phase 3 study simply because the bevacizumab is off patent, and that's why there is no enough enthusiasm or support for that. So these are the phase 2 studies done in HCC. A couple of those studies were done at our institution, showed a signal of activity. A few of them were done in Asia and showed some heterogeneous patient population as it is here, and also most of them were done in second line rather than front line. This is our completed second line study with bevacizumab and erlotinib at MD Anderson. So 44 patients, follow-up was long. 16 weeks progression-free survival was 43%, which was the primary endpoint. Median TTP was about 4 months, and median overall survival was about 10 months. So this is a second-line setting with bevacizumab and erlotinib. In fact, I use it for patients who are not candidates for clinical trials. So we have about 8 clinical trials, but those who cannot participate or had significant toxicity on any trial, and we have to do something off protocol, I do bevacizumab alone. Very tolerable. Those tumors are very angiogenic, and there are data. I showed you about 7 studies done globally showing the activity in this disease. And this is the first second-line study to be done in the West, and it's in submission now. So nivolumab, I touched briefly on the immunotherapy studies in the first talk, but we didn't have enough time to talk about the phase 1 study of nivolumab, which was about 27 patients. And you see here some 2 complete responses, small tumors, but complete response in uninfected patient population, some decent partial response and stable disease. So we're initiating a phase 2 study on nivolumab, so we're also excited about this, especially in the setting of some responses, complete response and partial and stable disease. MicroRNA is also an emerging concept. You look at it from different angles. A lot of biomarker studies looked into it from the invasion and metastasis standpoint in patients with metastatic disease, cell cycle regulation, signaling pathways, looked into also the correlation between the microRNA and the virus, causative virus, whether Hep B or Hep C. So you will see some of them are common players. One of them is the microRNA, the 122, and others. We're actually collaborating on a study with Mansoura University on this to study this in the Egyptian patient population as a marker of the disease biology and also as a potential therapeutic marker. So, but none has made it to phase 3 yet. Also, an emerging concept in the second line setting related to the cancer stem cells. There's a big rationale for it, especially in the liver, the differentiation of the progenitor cells to hepatocyte or bile duct cells. So none of them has made it yet to phase 3, but all in phase 1/2, focusing on the cancer stem cell biomarkers. The problem is there is no good target here, but it's evolving. So I wanted to dedicate some time, especially we have young physicians and medical students, to talk in general about those challenges facing us when it comes to phase 3 studies, which are necessary for any drug approval. So with too many studies failing in the phase 3 setting for hepatocellular carcinoma, I wanted to dedicate a few slides about this issue here. First, why are we concerned? Because all of these phase 3 studies, they be based on phase 2 studies. Most of them are inadequate to really answer the big question of go or no go. And the number of phase 3 studies is very high, especially in HCC, which raising the cost of the development and delaying the progress of the field, canceling some research support for other things in terms of new molecules and agents. So it's really a huge magnitude of a problem here. So of all agents in oncology under development, only less than 5% of them, in some reports 1%, make it to reach approval through phase 3 studies. So that's not a good turnout for business. While less than 5% of them made it to approval by phase 3 studies, if you look back at those agents who failed, you will see that 60 to 70% of them had successful phase 2 studies and yet failed when it came to phase 3 studies. So a substantial amount could be derived from good conducted phase 2 studies, even negative studies, which is a major problem. We don't really get to see those studies. Most of the published data are just about positive studies. You never see negative studies published in high impact journals, which is also a significant challenge because we need to know about negative studies to avoid the same mistakes, even repeating the same agent in a similar setting. So we'll talk a little bit about why those phase 2 studies are not really giving us the good signal as they're supposed to be. The primary objective of them is just to estimate the efficacy and determine whether the drug is promising or not. So very simple message, but it's very challenging because most of the phase 2 studies are very small. So if it is a 30% response rate in a phase 2 study, it's really not more than 10%, because if you look at this approach here, statistical design, 30% response rate from a large study is much more accurate than the same percentage in a smaller study. So that's one of the inherent challenges with phase 2 studies. How to overcome this? Of course, you have to increase your number or randomize. So the best approach is to have a multi-arm randomized design for phase 2 studies with standard of care treatment as a placebo arm or placebo controlled if there is no standard of care. Historical controls really don't work very well. So most of the phase 2 studies rely on historical controls, but you have to remember it's different patient population, different demographics, different risk factors altogether. So one of the very quick and low-hanging fruit solutions is to do a randomized phase 2 study to get a good signal and before you move to phase 3 study. However, to do a randomized study and rely on overall survival, you have to have longer follow-up, you have to have larger patient population. So that's another challenge which led to adopting time to tumor progression rather than overall survival when it comes to randomized phase 2. So that's another big challenge. So you have a randomized phase 2, but you rely on TTP instead of overall survival to see a signal, and then you move to phase 3 and you flip it over, and overall survival becomes the primary endpoint. So it's still a major problem. So the best design is to have a randomized phase 2 with overall survival as a primary endpoint, but it's going to have more patients on board and you have to follow them up for a longer time because most of the new agents are cytostatics. Another approach, which is also new, randomized discontinuation. So you enrich the study after you start the treatment. So you start the first stage and all patients are treated with one agent, and then the second stage will take those patients with stable disease and then you randomize them. But the problem here is this is very specific and amplifies the results. So it helps you to get a good answer, but it amplifies the results if you look at the patient population who are stable first and then you start randomizing them. The Bayesian approach is also fairly new, so it addresses the issue of the heterogeneity of the tumor and allows us to select subclasses of patients. So you look at the tissue biomarker profile and then you randomize the patients accordingly. So it's a sequential analysis kind of technique and relies on experience from prior studies. So the perfect example is a study we had with colon cancer. It's called the ATTACK study at MD Anderson, which looked into the tissue biomarker array for patients, and those with high EGFR went to an anti-EGFR, and those with certain mutations like RAS and so on went to different treatment regimens, RAF, kinase, and all of that, but still relies on our beliefs from prior studies. So also had some challenges related to that. So major challenges are related to the reporting of those studies, as we mentioned. So there is a lot of selective reporting of those results, as we mentioned earlier. There is a lot of post hoc analysis, or what we call data-driven analysis. So your primary endpoint would be TTP, but then you find a signal in terms of post hoc analysis. Patients had better quality of life, for example, and then you start highlighting this as being the major goal of the study. So this post hoc analysis doesn't work because it's basically retrospective. So that's an interpretation error. There is also discrepancy between protocols and publications. So most of the journals now require the protocol to be reviewed along with the publication itself. So that way they make sure that your original endpoints stayed the same, you didn't have the post hoc analysis. So that's very critical. And you find in major journals that the study published will have an attachment to it, which is the original protocol, to really help you out, because if there is a highlight in the discussion part about a post hoc analysis, you don't find it in the primary end, then you know that it's not reliable and this is just a retrospective kind of analysis. And also poor reporting and disclosure of the study details, so that's why people cannot even reproduce it. So in terms of bias reporting, it really depends on all of us as human beings. We tend to focus more on positive results. So less interesting findings to the author of the manuscript would not be highlighted. It's less likely to be published also. So partially it's because of the authors and partially because of the journals themselves. The discussion part of the publication always favors results with statistically significant p-values. So it's really complicated. Partially it's because of the authors, their bias to their data, peer reviewers also, they get biased about the data, so most of the editors will try to diverse, the reviewers to have a clinician, a basic scientist, and also a statistician. So whenever you're submitting a paper, it's much better if you're suggesting reviewers to also give this diversity. So don't give them 3 clinicians, just try to diverse it, because they will end up doing that to get some different views. So the peer review process is also very critical to publishing those data. Of course, the media anchors, they tend to pick up the catchy titles and the positive results rather than focusing on negative results. So what can we do about that? If we know that poor reporting is one of the major challenges we face, and what makes us come across a lot of negative phase 3 studies. So it really starts from the local institutions. So research conduct guidelines through the local IRB, which is Institutional Review Board, is very critical here. So initially, the IRB should be looking at not only the study design and statistics, but they should have the power to suggest some changes. So most of the IRBs now focus on a diverse population within the IRB itself. It has to be clinicians, scientists, statisticians, and also even patient representatives. So if you have this diverse institutional review board, you can really overcome that from the beginning. So you have a good study reviewed by a team that gives some suggestions in terms of the study concept and monitoring. Monitoring is also very, very critical to reporting of any potential side effects and so on. Patients have the right to know if there is any emerging major side effect or data. They have the right to have the data disclosed to them at any point. Journal instructions to authors are also very, very critical. So key details of the study are important, down to the simple detail of storage temperature of biomarkers. Even if you have the centrifuge, how many RPM when you centrifuge, for how many minutes, all of these simple details are very critical to reproducing those results. So those are also required by most of the journals. The stats also get reviewed by statisticians, so this is not only for manuscripts submitted for publication, but also any grant, any NIH grants, they have to have a statistician revision for that reason. To look into original data correlation with the manuscript to allow the readers to reproduce it. Also informed knowledge reporting through the media anchors. So nowadays we should be seeing more media anchors who are medical or have some good medical background, so that way they can appreciate negative results as well as positive results and help the general public get to know this. This is a very quick snapshot at how detailed reporting is becoming very big when it comes to clinical trial publications to avoid those negative phase 3 studies. So here you look at the box stuff here are the ones I wanted you to focus on. So the pre-specified hypothesis, so that's why the original protocol is very, very critical. And then the sample characteristics, we talked about that, whether prospective or retrospective. When you have a biomarker study, you have to talk about the cut point determination, and also looking into interpreting the results in the context of the pre-specified hypothesis. So it goes back again to what you really intended to do in the first place. Did you achieve that or not? If you did not achieve it, this is still very valuable information, because we need to know negative results as much as we need to know the positive results. So I'll end with this quote: accurate and transparent reporting is like turning the lights on before you clean up a room. It doesn't clean it for you, but it does tell you where the problems are. So this summarizes the issues we have with the reporting. So let's conclude here. So there are no drugs currently approved for second-line setting for hepatocellular carcinoma. We talked about studies that are in progress, studies that failed in the phase 3 setting. We talked briefly about the bevacizumab story and why it didn't move to phase 3 study, and why we use it sometimes off-label for this purpose. And it's really clear that one of the major challenges to positive phase 3 studies is ineffective phase 2 studies. So we talked about the challenges in designing and implementation of the phase 2 studies. We talked about some suggestions about good phase 2 studies to enable us to have a better chances of positive randomized phase 3. So providing adequate information from phase 2 study would really help us picking up which promising agents to move to phase 3 setting. Has to be also biomarker driven in this era of targeted therapy studies. So pre-planning of phase 2 programs really require a good idea about your rationale for it, biomarker selection for targeted therapy, and also helps you out in terms of the publication for other people to reproduce it. So the take-home message is you really have to read with caution any phase 2 study before you pick it up and try to move to phase 3. Cannot fully rely on the authors or the peer review because we talked about a lot of biases and challenges with reporting and so on. Published reports doesn't mean it is sound. You really have to use your own judgment. Must rely on your training, experience to understand, interpret, and apply those new findings to your knowledge about designing a phase 3 study in HCC. So hopefully this will help us achieve positive results from future phase 3 studies for HCC. I'd like to acknowledge my team again and thank you so much for your time.
Thank you, Dr. Ahmad. Dr. We can start the discussion for not more than 5 questions. لا خليهم دكتور مدحت. لا مش
هو السؤال كان له يعني لكن الموجود يجاوب يعني. For how long do you have to survey cirrhotic patients after the sustained viral response for hepatocellular? Because in ex-smokers, you have to survey for 8 years after stopping smoking. 8 years. Because the tumor will take 8 years to reach from a small colony to a centimeter, which can be seen by the CT scan to the chest. I know that Dr. Imam Waqid said for life, but I think this is not practical. What do you think, Ahmed Asr? Kasif? What do you think, for how long we have to survey patients with hepatitis C virus who have sustained the viral response, negative?
I'm a medical oncologist. I cannot claim to know the right answer, but I think in general, because having seen thousands of patients with Hep B, I like those slides about the recent studies. Even if you clear your Hep B, you're still at risk for hepatocellular carcinoma. I think the same thing applies to hepatitis C. We're still on the learning curve, so I think even if the virus gets cleared, personally, when we do something like this and clear the virus and do resection, we still follow them up every 6 months, regardless.
Yeah, but for how long? How many years? For example, you may not listen to my... Because the ex-smokers who stopped smoking, you have to survey them for 8 years.
Right. So,
with the annual CT check.
So if you look at the molecular pathogenesis of hepatitis B, for example, it doesn't have to do with clearance of the virus. So it's basically the DNA mutation caused by the first infection process. So even if the virus is cleared, they are still at risk for life. For hepatitis B, I would say for life, because we've seen this mutation based on the integration. It's a DNA virus, so it integrates into the human genome. So even if it is cleared for life, they should get screened. For Hep C, it's a learning curve. I don't know with the new drugs and all of that, we're still going to learn. But personally, I do this for life after resection, for example.
Okay, thank you.
Your question about that the established cirrhosis.
Well, established cirrhosis.
If there is established
one
cirrhosis-
part of the question, or no cirrhosis.
In the established cirrhosis, follow-up for life, because he could develop HCC. It's not like smoking. It's not like the lungs. For life, because the tissue changes could develop HCC at any point of time. So this is for life, even for HCV.
Okay, you answered that there is molecular changes. Thank you.
Okay, Dr. Ahmed Kassi, thank you very much for the two presentations. And I augment your idea about that there is many negative trial about hepatocellular carcinoma and nobody knows about this trial. Myself in the National Cancer Institute involved in the LIGHT protocol, and you know the LIGHT protocol, they're comparing linifanib versus sorafenib, and it is an inferiority study and nobody knows about this study, while during doing the study it was showing a very worldwide recommendation or celebration. So it is again negative study, and as you mentioned, the Nexavar, the lucky Nexavar will stay for a long time because it benefits some survival in those poor patients. Now my question, I have many trials in the National Cancer Institute with the pathologists showing that topoisomerase alpha 1 is very important in deciding which type of chemotherapy and not targeted therapy, because again we are a very poor country with limited resources, and for your information we have a lot of advanced inoperable hepatocellular carcinoma in a young age in a good performance status, and we as a medical oncologist, this makes us a conscious pressure, and still we cannot offer them either Nexavar or breast supportive treatment. We have to find what is beyond Nexavar. So my question is a very practical one. In patients who failed Nexavar and still have a good performance status, do you ever have some selection to start standard chemotherapy, either local chemoembolization or systemic or together? Just 1 minute, because I know the MD Anderson few years ago involved in a trial, 5 drugs bi-weekly, either systemic or by chemoembolization.
Yeah, so it's a good question, of course. So I think what the problem in Egypt is we don't know anything about the molecular pathogenesis of the disease. So the natural history is not known. So we did this study with Asyut University, 100 patients, and looked into clinical pathologic features. So the disease is more aggressive in Egypt, just looking at 100 patients. Younger patients, more association with metastatic disease, vascular invasion, and so on. And response to treatment was also inferior. So I think there is a big gap in terms of understanding the molecular targets for the Egyptian population, and we cannot rely on data from the West, even if it is hepatitis C, because we have a different genotype. So I think if you're a pathologist, I think it starts there to look into molecular profiling and mutation analysis and genomics and so on, so you can get to understand the disease better. The next step would be to have your own studies and validation studies in your patient population. So most of the drug companies, they have international studies. They want to include some patients from the developing countries, but in the end, there is really less promise of enrolling enough patients to get a good signal. You end up having 10-15% of the global study population, so you don't have enough evidence about the efficacy of the drug, and you don't even have access to the drug because most of these drugs are very expensive, so it's not fair to your patient population to submit to being part of the study, and in the end, they don't even have access to it. So I think it starts from here, policymakers and some, work with the WHO to try to have your own studies for your own patients, just 100% Egyptian patients, focusing on your risk factors and demographics. Off protocol, I always try to find a reason to do chemotherapy if they don't have cirrhosis and if their hepatitis is very well controlled. So the regimen you talked about was the one I showed, PF regimen, platinum, interferon,